Hi guys, in this video we're going to be discussing about arteriosclerosis and atherosclerosis, and it's going to cover the definition of arteriosclerosis, the classifications into atherosclerosis, arteriolosclerosis, and Monckeberg medial calcific sclerosis. And for each of them, we're going to be discussing the definition, etiology, pathogenesis, and the findings. However, for Monckeberg medial calcific sclerosis, we're just going to have a very brief 1 to 2 sentence overview because it's not as relevant for the exam as these other two. So, starting with arteriosclerosis, it literally translates into hardening of arteries because arterio means artery and sclerosis is hardening. Generally, there is a thickening of the blood vessel, and with this thickening, there is a decreased compliance. The decreased compliance also causes them to be less elastic. And if they're less elastic, they're not going to be recoiling as expected to the pressure changes. So there's going to be a lower pulse pressure. If you guys remember from physiology, it's the difference from the systolic value and the diastolic value, and that's given as the pulse pressure. And when there's decreased recoil, decreased elasticity, there's a decrease in the pulse pressure as well because they're not going to be able to accommodate for that larger range with the loss of elasticity. And because of this, there's also an increased afterload. With an increased afterload, the left ventricle has to work harder to get blood into the systemic circulation. Uh, the types are basically atherosclerosis, basically mainly affecting the large muscular arteries, arteriolosclerosis affecting the arterioles, and the last one, the Monckeberg needle calcific sclerosis, just affects the tunica media of blood vessels, medium arteries. Now, atherosclerosis, hardening of arteries, causing luminal narrowing, affecting blood flow. The main thing you should know is it is the hardening of arteries, and as a consequence of the hardening, there is luminal narrowing, and with luminal narrowing, there is a decreased flow, blood flow. Most commonly affects the abdominal aorta, the coronaries, the popliteal, and internal carotid. Now, it is very important that you mentioned the coronary artery and the internal carotid because they are usually the most significant ones. Having atherosclerosis or atherosclerotic plaques in the coronary arteries and in the internal carotid artery really affects blood flow to two major organs which are responsible for keeping you alive. Uh, with the coronaries, decreased blood flow is gonna can cause myocardial infarctions, and with decreased blood flow through the internal carotid, it can cause stroke. Slower progressing disease, complications usually manifest later in life. Now, it's also a multifactorial disease with multiple risk factors, and the risk factors are then further divided into modifiable and non-modifiable. And they basically mean that the modifiable risk factors can be influenced by the individual's choices in life. However, the non-modifiable ones are, as the name suggests, not changeable, and they basically include for modifiable the cholesterol levels, mainly of LDL, smoking, diabetes mellitus. Obviously, diabetes mellitus is once you get it, it's technically not modifiable, but it's modifiable in the sense that you can prevent yourself from becoming diabetic and hypertension. Usually, it's modifiable only in the case of secondary hypertension, as it depends on an underlying pathology. But for primary hypertension, it would technically be classified as non-modifiable. And then for non-modifiable risk factors, we have age. Risk increases with age. Genetics, genetics now are depending on two things. It's the genetics of uh, cholesterol and basically if you have any lipidemias, such as if you have familial hypercholesterolemia or familial hyperlipidemia. That's one aspect of genetics, and the other aspect of genetics is basically whether your parents had diabetes and hypertension. For individuals whose parents had both diabetes and hypertension, they are at a 8 times greater risk for developing atherosclerosis in their life than the average person whose parents did not have diabetes or hypertension. That's the sense of genetics, and then your gender is also uh, a non-modifiable risk factor. That's why females are more prone to this because of postmenopausally their estrogen levels are decreasing, and estrogen is protective against atherosclerosis. And more information about how estrogen is protective can be found in the female reproductive pathologies. Moving on, now the pathogenesis is basically a seven-step process. There's an extra eighth step, but that's not technically part of the pathogenesis. It's just a later change that can occur, a secondary change. Now, the best way to describe this in the exam would be as a response to injury model. That basically means that atherosclerosis is nothing but the body's response to injury via inflammation. And you'll see that because step one is endothelial damage and dysfunction. Now, there are multiple causative agents that can lead to endothelial damage, and they include diabetes mellitus, hypertension, and smoking. How does diabetes cause damage to the endothelial wall? Is because with hyperglycemia, prolonged hyperglycemia, this leads to non-enzymatic glycation of proteins on the endothelial surface, and they produce AGEs or AIDS, which are advanced glycation end products. And these age can take part in something known as RAGE-age interaction, which is damaging. RAGE is a receptor for advanced glycation end products. Many of you might have covered this in uh, Pathobiochem 3, but a small portion of this was also covered in biochemistry. Hypertension, how does hypertension affect the endothelial wall? Because increased blood pressure is damaging to the endothelium. And with damage to the endothelium, it can cause uh, fissuring and all. Smoking, obviously, are risk factor for many things, and there are different different types of chemicals which can cause endothelial damage via smoking. And this leads to the damage leads to increased vascular permeability and leukocyte adherence and thrombosis. So basically, you get the steps of inflammation after injury. Step two is lipoprotein accumulation. So in your blood, you have LDLs, VLDLs, HDLs, all being transported regularly. And what happens is that they start accumulating. Mainly LDLs start accumulating in the vessel wall. Step three is monocyte adhesion. So this gets, once it starts progressing even more, you get monocyte adhesion. Basically, it's macrophages. So monocytes will be attracted to this site of injury. They will migrate into the vessel wall, and then they will transform into macrophages. And these macrophages will start eating or clearing up this LDL deposition, this lipoprotein deposition, and they're going to transform into something referred to as foam cells. And this is where the first visible microscopic, or it's not technically microscopic, it can also be seen macroscopically with your eyes, is the first change, which are referred to as fatty streaks. Fatty streaks are basically within the blood vessel wall. You can see this uh, on autopsies, that you see these white to yellow pale streaks on the vessel wall, and they basically comprise of macrophages, which have transformed into foam cells and engulfed these lipid molecules. Next step is platelet adhesion, because since the subendothelial matrix is exposed to the blood flow, it will promote the coagulation cascade, or it'll promote blood clotting. Then factors are going to be released from activated platelets, different, like a number of them, that will cause smooth muscle cell proliferation, ECM production, and T cell recruitment. Then what happens is you have lipid accumulation once again, both extracellularly and intracellularly. And with step 6 and 7, it transforms from a fibrofatty it transforms from a fatty streak into a fibrofatty atheroma. And the fatty streak is basically at the level of the blood vessel. There's no elevation into the lumen, there's no obstruction into the lumen. However, once it transforms into a fibrofatty atheroma, it becomes an elevated plaque. And this elevated plaque, if is large enough, can start occluding blood flow, can start disturbing blood flow into the tissues. And then what happens is the eighth step, technically, or the secondary change over time, is calcification of the extracellular matrix and necrotic debris in latent pathogenesis. So this is a type of dystrophic calcification with normal levels of calcium in the blood, but there is necrosis as well. That's why it's dystrophic calcification, and then this is termed as a complicated calcified lesion of in atherosclerosis. And this is just a diagram showing how the progression of atherosclerosis looks like. So initially there's damage, fibrofatty streak, then intermediate lesion as it slowly progresses, and then you get an atheroma. And the atheroma can then grow, become calcified, and start obstructing the blood flow. Now, as for the morphology, how would you describe this in the exam if they asked you how would an atherosclerotic plaque look like? You would say it's going to be a whitish to yellow elevated uh, mass on the internal surface of the blood vessels. And if it is calcified, it's going to be extremely hard and sharp as well. So that's how you're going to describe it macroscopically. Uh, as I mentioned, now complications, it can be in the acute and chronic sense. Acutely, what we get is acute plaque changes. So the plaque can rupture, erode, or ulcerate the endothelium, and this basically, all these will expose the damaged endothelium to the blood, and with that you will have platelet plug formation, and basically thrombus will produce. Now this thrombus can embolize and basically lead to a thromboembolism, somewhere more commonly in the lungs. It could be uh, or basically since it's in the mainly in the arterial system, what happens is that they can occlude smaller arterioles and prevent blood flow into those tissues. Chronically, you get vascular stenosis, which is luminal narrowing over time, lethal in colonies in carotids, as I mentioned earlier. And there is a term known as critical stenosis. It is usually 70% of the cross-section area being occluded of the vessel, and mainly leads to myocardial infarction and stroke. And if it is in other organs, so it is basically atrophy and ganglion formation in the lower extremities, secondary change with ischemia. And weakening of vessel wall over time, it can lead to aneurysms and dissections. Now, moving on to arteriolosclerosis. This is the hardening of arterioles, restricting blood flow into tissues. There are two main morphological findings, and each of them have a different etiology. Now, you have hyaline arteriosclerosis, deposition of proteins in the vessel walls, mainly seen in benign or chronic hypertension and diabetes mellitus. On organ-specific complications, and mainly the main one you need to know about is chronic renal failure. So what happens is basically because of this increased blood pressure or damage to the endothelial wall. It causes extravasation of proteins from the blood into the vessel, and that's why it is termed hyaline, because of the presence of proteins uh, in the vessel wall. And renal failure, because if you have decreased blood flow to the kidneys, it will basically cause uh, uh, what happens is that yeah, so as I was saying, so they become blocked, and then it causes glomerular scarring, and the glomerular scarring leads to chronic renal failure. And this can also be seen more in the questions from the kidney pathologies. One of them, I think, talk about nephropathies. So in that, there's going to be more details. Then you have hyperplastic arteriosclerosis or arteriolosclerosis. You see this. This is basically reactive hyperplasia of smooth muscle, causing luminal narrowing with fibrinoid necrosis. Seen in malignant hypertension, also known as acute hypertensive crisis, and it is also again organ-specific complication. But most common one is flea-bitten kidney. What happens in that is uh, because of this increased blood pressure, this extremely high blood pressure, it causes a rupture of these small thin arterioles, causing many small hemorrhages throughout the cortex of the kidney. So you will see a flea-bitten kidney. And then for Monkeberg medial calcific sclerosis, calcification of the medial layer of muscular arteries, non-obstructive, hence clinically silent and insignificant, and it is basically incidentally found on X-rays and mammography. This is a straightforward question. Just know the key terms and the morphologies, and you're going to be good in the exam. Thank you for watching.